to the Kanski lecture series Eyelids part 8, and in this part we are going to discuss about the blepharitis. So blepharitis is a very important topic because it is one of the most frequently encountered disease in OPD. So we are going to discuss about the chronic blepharitis. Why it's chronic? Because the patient present with a chronic and long term symptoms of dry eyes. The patient may complain of irritation, ocular discomfort. So these are one of the symptoms of the blepharitis, and it is very long term disease. So introduction: chronic blepharitis or chronic marginal blepharitis is a common cause of ocular discomfort and irritation. The poor correlation between the symptoms and the sign, the uncertain etiology and mechanism of the disease process all combine to make the management difficult. Blepharitis may be subdivided into anterior and posterior forms, although there is a considerable overlap, and both types are often present, mixed type. So basically, chronic blepharitis is can be anterior or posterior. What is blepharitis? Basically, blepha mean eyelids and itis mean inflammation. So blepharitis mean the inflammation of the eyelid, and it can involve the skin portion, which is called the anterior blepharitis, and the posterior, in which the meibomian glands are affected, which is also sometimes known as meibomian gland dysfunction. Anterior blepharitis affects the area surrounding the bases of the eyelashes and may be staphylococcus or seborrheic. It is sometimes regarded as related more to the chronic infective elements and hence more amenable to treatment and remission than the posterior form. And etiological factors in staphylococcal blepharitis may be an abnormal cell-mediated response to the component of the cell wall of the staph aureus, which may also be responsible for the red eyes and peripheral corneal infiltrate seen in some patient. It is more common and more marked in patients with atopic dermatitis. Seborrheic blepharitis is strongly associated with generalized seborrheic dermatitis that characteristically involve the scalp, nasolabial fold, skin behind the ears, and the sternum. So one thing very important, the causes of anterior blepharitis is two types. One is seborrheic and other is staphylococcus and other is seborrheic. So the staphylococcal blepharitis patient usually have another disease entity known as atopic dermatitis, whereas seborrheic blepharitis patient has also a disease called the seborrheic blepharitis. Basically, the seborrheic, let's first discuss about the seborrheic blepharitis. The seborrheic blepharitis or seborrheic dermatitis is very common condition, especially in cases of infant, and what you will see is the dryness and the scaling of the skin that will occur, and the dryness and the scaling usually affect the scalp. It can behind the ears and the sternum area, and it also affect the eyes. When it affect the eyes, it is called the seborrheic dermatitis, and it involves the skin. The next is the staphylococcal, and the staphylococcal blepharitis is blepharitis is basically the disease condition in which the patient is having a sensitivity to the component of a staph aureus, which is usually normally present in the skin, and what it causes the blepharitis. And such patients usually also have a condition known as atopic dermatitis. Posterior blepharitis is caused by the meibomian gland dysfunction and alteration in the meibomian gland secretion. Bacterial lipases may result in the formation of the free fatty acid. This increases the melting point of the meibum, preventing its expression from the gland, contributing to the ocular surface irritation and probably enabling the growth of staph aureus. Loss of the tear film, phospholipid that acts as a surfactant, result in the increased tear evaporation and osmolarity and unstable tear film. Posterior blepharitis is commonly thought of as a more persistent and chronic um, inflammatory condition than anterior blepharitis, there is an association with an acne rosacea. So basically, posterior blepharitis is much more common than an anterior blepharitis. What you can see is there is a, you know, gray line, and behind the gray line is a meibomian gland orifices, and you can see the capping of that area. Basically, meibomian gland has a function of producing a meibum or a lipid layer of tear film. So you know that tear film has a three component: lipid layer, aqueous layer, and mucil layer. And the lipid layer is produced by the meibomian gland. So when this layer is deficient, what will it cause? It will cause the increased evaporation of the aqueous layer of the tear film, and it will cause the tear film dysfunction, and there will be the dry eyes that will be associated with the blepharitis. And another thing very important is that acne rosacea is associated with it. Another thing is that important thing is because there are bacterial lipases when it is associated with the infection also, that staph aureus, there will be the bacterial lipases. What will it do? It will increase the formation of the free fatty acid. And what will it do? It will increases the melting point of the meibum, and it will not allow the meibum to produce from the meibomian gland. A reaction to the extremely common hair follicle and the sebaceous gland during mite, Demodex, and other microorganisms may play a causative role in some patients. Demodex follicularum longus in anterior blepharitis, and Demodex follicularum brevis in posterior blepharitis. Though the mite can be found normally in the majority of the older patients, most of whom do not develop symptomatic blepharitis, has been proposed that circumstances such as overpopulation or hypersensitivity, perhaps to a bacillus carried symbiotically by Demodex, may lead to symptoms. Demodex mites are the major cause of the animal damage disease mange. So basically, another thing, there are certain kinds of mite that are maybe present on the hairs, lashes of the eye, and Demodex is very common. And in case of the anterior blepharitis, the causative organism is Demodex longus, and in case of posterior, it is follicularum brevis. And basically, it the hair follicles and sebaceous glands are become hypersensitized to these kinds of mite, which causes the symptoms of blepharitis. So you can see the figure table 2.1. It is showing the different kind of blepharitis, interior blepharitis and posterior blepharitis. One of the most important thing that you must know according to the MCQ's point of view is the associations of the blepharitis. So basically, the anterior blepharitis, staphylococcus is associated with atopic, seborrheic with the seborrheic dermatitis, posterior blepharitis with the acne rosacea. So in cases of the staphylococcus, the lashes will have a hard exudates, deposits, and loss of lashes will be also there. This trichiasis will be also there. There can be ulceration, notching, hordeolum, phyllectenule. Basically, phyllectenule is a process in which the staphylococcus is causing the peripheral ulcerative keratitis in the patient, and it is causing the hypersensitivity. And phyllectenule is basically the nodule formation in the conjunctiva. Foam in dry eye is also present. Punctate erosion, vascularization is also present. Infiltrates is also present. In case of seborrheic, the exudates are usually soft. There can be the loss of eyelashes. There can be districhiasis. There can be dry eye, punctate erosion, vascularization, and infiltrates. In case of posterior blepharitis, there can be notching, meibomian gland dysfunction can be present. Foaming can be present, dry eyes are present, punctate erosions are present, vascularization and infiltrates are also present. So, how do you diagnose the disease? Involvement is usually bilateral and symmetrical with no visual disturbance. Symptoms are caused by the disruption of the normal ocular surface function and the reduction in the TF stability, and are similar in all forms of blepharitis. Now, stinging may be more common in posterior disease because of the poor correlation between the severity of the symptoms and the signs. It can be difficult to objectively assess the benefit of the treatment. Burning, retinitis, mild photophobia, and crusting and redness of the lid margin with remission and exacerbation are characteristic. Symptoms are usually worse in the morning, although in patients with associated dry eye, there may be an increase in during the day. Contact lenses may be poorly tolerated. So basically, the patient of blepharitis usually present with the symptoms of dry eye. The patient may present with the burning, itching, and also the crusting of the eyelids, and the contact lenses are poorly tolerated. So now what are the signs of blepharitis, staphylococcal blepharitis? As you know, the exudates will be hard. Hard scales and crustings are found mainly located around the base of the lashes and are associated with coloratae, which are cylindrical collection around the lash bases. So let also remember that staphylococcal blepharitis are usually anterior type of blepharitis. So the lash follicles may have the crusting and the formation of coloratae. You can see that here. Mild papillary conjunctivitis and chronic conjunctival hyperemia are common. Long-standing cases may develop scarring and notching of the lid margin. Madarosis, which means that there will be the loss of the eyelashes. Trichiasis means in the inversion of the lashes. Poliosis means the whitening of the lashes. Associated tear film instability and dry eye syndromes are common. Atopic keratoconjunctivitis may be present in patients with atopic dermatitis. Seborrheic blepharitis, hyperemic, greasy interior lid margin with a soft scale and the adherence of the lashes to each other. So these type of blepharitis, seborrheic blepharitis, will have a greasy exudates. You will see that it is like a oily type, and it will and there will be the adherence of the lashes to each other. So you can see figure 2.42a showing the chronic interior blepharitis. A is showing the scales and crusting including coloratae, greasy, and B is showing the greasy lid margin with sticky lashes in seborrheic blepharitis. So these are sticky lashes. Posterior blepharitis, meibomian gland disease, excessive and abnormal meibomian gland secretion, manifesting as a capping of the meibomian gland orifice with oil globule, pouting, recession, or plugging of the meibomian gland orifices. So, in case of the meibomian gland dysfunction, you will see that the meibomian gland are usually capped with the oil globules, and so it is showing the A is showing the capping of the meibomian gland by oil globule, and B is showing the plugged meibomian gland orifices, and C is showing the expressed toothpaste like material. When you press the lid margin, they press the lids, then there will be the expression of the cheesy material from the eyelid, and D is showing the frothing of the eyelid margin. So in these are all the signs of the blepharitis. Posterior blepharitis, hyperemia and telangiectasia of the posterior lid margin. Pressure on the lid margin result in expression of the meibomian gland fluid that may be turbid or toothpaste-like. In severe cases, the secretion becomes so insipid that expression is impossible. Lid transillumination may show gland loss and cystic dilatation of the meibomian gland. The tear film is oily and foamy and often unstable, and froth may accumulate on the lid margin or inner canthi. So these are all the signs of the posterior blepharitis. Another is the demodex infestation. Basically, the demodex is a kind of a mite that you may find on the lashes, and it can cause the blepharitis with it. Demodex infestation may lead to the cylindrical dandruff-like scaling colorate around the bases of the eyelashes, though this is not always present. The mites may be can be demonstrated under 16x slit lamp magnification by first manually clearing around the bases of the eyelashes and then by gently rotating the lash or moving it side to side for 5 to 10 seconds with fine force. If one or more mites 0.2 to 0.4 ml long do not emerge, the lash should be gently epilated. Slide microscopy can be performed on the mite or lashes if necessary. So in this case, what you do is that you do the slit line examination, and you try to first clear the base of the lashes from the exudates, and then you gently rotate the eyelashes and you see the mite can be present on the slit lamp. Secondary changes include papillary conjunctivitis. So these are all the things that can present associated with blepharitis. So it is a very common association, and we must remember that one is the papillary conjunctivitis, inferior corneal punctate epithelial erosions, corneal scarring and vascularization, including the Salzmann nodular degeneration, and advancing wave-like epitheliopathy, type changes, sty formation, marginal keratitis, and occasionally bacterial keratitis, especially in contact lens wearer, and phyllectanular eye disease. So basically, the Salzmann nodular degeneration is the age-related degeneration in the cornea, but the blepharitis can be associated with it. So how will you treat that? First of all, you have to treat the eyes like you lubricate the eye and give the lid hygiene. Lubrication means you try remove the dry eye symptoms from the patient. There is a little evidence to support any particular treatment protocol for blepharitis. Patient should be advised that a permanent cure is unlikely, but control of symptoms is usually possible. The treatment of anterior and posterior disease is similar for both types, particularly as they commonly coexist, but some treatments are fairly specific for one or the other. Lid hygiene can be carried out once or twice daily initially, although compliance and techniques are highly variable. A warm compress should first be applied for several minutes to soften the crust at the bases of the lashes. Lid cleaning is subsequently performed to mechanically remove crust and other debris, scrubbing the lid margin with a cotton bud or a clean face cloth dipped in a warm dilute solution of a baby shampoo or sodium bicarbonate. Commercially produced soap or alcohol impregnated pads for lid scrubbing are available and are often effective, but care should be taken not to induce mechanical irritation. So what you do in this treatment is basically you ask the patient to use something warm, like a warm cloth, and what will it do is basically the warmness can soften the crusting at the bases of the eyelashes. So when the bases is soft, then you what you do is you take the baby shampoo and you dilute it in water, and then you clean the eyes with that of the with the dipped in with the cloth dipped in that solution. And there are certain kinds of products that are also available commercially for the use of blepharitis. When substantial meibomian gland disease is present, the regime may include the expression of the accumulated meibum by rolling the finger interiorly over the margin. So this is, you can also when do massage of the eyelid so that there is an expression of the the meibum from the eyelids. The putative action of the lid hygiene against demodex is via prevention of reproduction. Lid hygiene can be performed less frequently as the condition is brought under control. So antibiotics. So what are the use of the antibiotics in the case of blepharitis? So antibiotics are given when the cases are associated with the in staphylococcal blepharitis, and there is an sensitivity to that staph aureus wall. So antibiotics are topical sodium fusidic acid, erythromycin, bacitracin, azithromycin, or chloramphenicol is used to treat active folliculitis in anterior disease. and is occasionally used for an extended period. Following lid hygiene, the ointment should be rubbed onto the interior margin with cotton bud or clean finger. Oral antibiotic regime include doxycycline 50 to 100 milligram twice daily for 1 week, and then daily for 6 to 24 weeks. Other tetracyclines or azithromycin 500 milligram daily for 3 days for 3 cycles at 1 week interval. Antibiotics are thought to reduce the bacterial colonization and may also exert other effects such as reduction in staphylococcal lipase production with tetracycline. Tetracycline may be more effective in the treatment of posterior disease and azithromycin in anterior. Tetracycline should not be used in children under the age of 12 years or in pregnant or breastfeeding women because they are deposited in the growing bone and teeth. Patients should be aware of the possibility of increased sun sensitivity. Erythromycin 250 milligram once or twice daily is an alternative. So basically, that whenever the chronic blepharitis patient present, then there can be the bacterial colonization in that patient as well. So to prevent it, we use the antibiotics. So for anterior blepharitis, the tetracycline is an antibiotic of choice. In posterior, it is the azithromycin. And how we use azithromycin is basically we give the azithromycin 500 milligram for 3 days, and then we do the 1 week. After 1 week we repeat the course, and this happen for the 3 weeks. And the tetracycline are given, in which the doxycycline is given for the 1 week twice daily, and then we give it for 6 to 24 weeks for once daily. And there are certain conditions when the tetracyclines are contraindicated, like in pregnant, breastfeeding women and children, and in those patients we use the erythromycin. Plant and fish oil supplements have been shown to be substantial benefit in some cases. Topical steroid or low potency preparations such as fluoromethanol 0.1% or loteprednol 4 times daily for 1 week is useful in patients with substantial active inflammation, especially papillary conjunctivitis. Occasionally, a higher strength preparation is used. So, topical steroids are also used in the case of blepharitis because of the inflammation to settle down. And tear substitute and other dry eye treatments are typically helpful for associated tear insufficiency and instability. Tea tree oil has been suggested as a treatment based primarily on its likely activity against Demodex infestation. The optimal vehicle and regime have not been established, but the lid, eyebrows, and periauricular skin cleansing once daily with 50% scrub and application of the 5% ointment has been described. So, in case of the Demodex, tea tree oil, which is a very good oil for even the skin conditions, we use it for the eyes. And what we use it 50% scrub for once daily, and we apply the ointment as well. Topical permethrin and topical 1% cream or oral 2 doses of 200 microgram per week, 1 week apart. Ivermectin have also been used by some practitioners. High temperature cleaning of bedding, the use of the tea tree shampoo and facial soap, and treating the patient partner may also all help to reduce recurrences. Novel therapies include topical cyclosporin, pulse light application, purpose designed devices to probe heat and or expression of the meibomian gland, lipid flow in posterior diseases. Complications are treated specifically. So that's it for the blepharitis. Now we are going to discuss about the thyraisis palpebrarum. Basically, palpebrarum is the eyelids are called, and these are some kinds of mite that are also affecting the eyelashes. The crab louse Phthyrasis pubis is adapted to living in pubic hair, but is also commonly found in other hair covered body areas such as chest, axilla, and the eyelid. Phthyrasis palpebrarum. So these are the lice, or you can say louse, that are present in the eye, and when it is present in the eye, it is called the phthyrasis palpebrarum. Symptoms consist of the chronic irritation and itching of the lid, but the lice are often incidental discovery. Conjunctivitis is uncommon. The lice are readily visible, anchored to lashes. Lice have 6 legs rather than 8, possessed by the tick. Ova and the empty shells appear as oval, brownish, opalescent pore adherent to the base of the cilia. Treatment consists of a mechanical removal of the lice and their attached lashes with fine forceps. If necessary, topical yellow mercuric oxide 1% of petroleum jelly can be applied to the lashes and the lid twice a day for 10 days. Delousing of the patient, family member clothing and bedding is important to prevent recurrences. So basically, as in lice in the hair, which causes a lot of irritation, when itching, the lice in the eyelid also cause itching. So basically, it is a having an 8 legs. So you can see this is a with hierasis palpebran, and this is the ova of that with hierasis. And what we do is mechanically remove that lice, and sometimes we can also use the petroleum jelly. Tick infestation of the eyelid. Tick can attach themselves to the eyelids and should be removed by the earliest opportunity in order to minimize the risk of contracting a tick-borne zoonosis such as Lyme disease, Rocky Mountain fever, African tick bite fever, or tularemia. So basically, why we remove it, so to prevent any kind of the systemic disease associated with that. One of the very common is Lyme disease and tularemia. If the tick is attached some distance from the eye, such as that spray can be easily applied. An insect repellent containing pyrethrin or pyrethroid should be sprayed on the tick twice at interval of a minute. Alternatively, a scabies cream containing permethrin can be applied. These have a toxic effect that prevents the tick from injecting saliva, and after 24 hours, it should drop off, or it can be removed with fine tipped forceps at the slit lamp. Blunt tipped needle holder are an alternative in restrained small children. It is critical that the tick is detached as close to the skin attachment as possible in order to remove its head and mouth part, following which it might be retained in sealed packaging to permit identification if necessary. In areas endemic for Lyme disease, some authorities suggest routine antibiotic prophylaxis with doxycycline following a confirmed deer tick bite. Patients should be told to seek medical advice urgently at the onset of suspicious symptoms, particularly erythema migrans. Over the subsequent few weeks, Lyme disease transmission is thought to require attachment of the tick for at least 36 hours. African tick bite fever is a rickettsial infection which is fairly common in the sub-Saharan Africa. The onset of the symptoms usually occur 4 to 2 days after the bite. So basically, what you do is whenever you are suspicious of the tick, you can use the spray insect repellent, which is quite dangerous. We use it on the insects. We spray in the closed eye, and what we do is in an interval of 1 minute we do spray it 2 times, and when the tick is tied, we remove it with the forceps. And if there is a suspicion of the Lyme disease, we can give the antibiotic prophylaxis doxycycline for the Lyme disease as well. Angular blepharitis. The infection is usually caused by the Moraxella lacunata or Staph aureus, although other bacteria and rarely herpes simplex have also been implicated. A red, scaly, macerated, fissured skin is seen at the lateral or medial canthi of one or both eyes. Skin chafing secondary to tear overflow, especially to the lateral canthus, can cause similar clinical picture and may also predispose to infection. Associated papillary and follicular conjunctivitis may occur. Treatment involves the topical chloramphenicol, pacitresin, or erythromycin. So basically, it is the canthi angular area of the eyes are affected. So that is why it is called blepharitis. And one of the important thing just you only should know about the blepharitis is the organism of associated with it. It is the Moraxella lacunata or Staph aureus, and it causes the redness, fissuring and scaling of the skin, and the treatment is with the antibiotic. Childhood blepharokeratoconjunctivitis. Childhood blepharokeratoconjunctivitis is a poorly defined condition that tend to be more severe in Asian and Middle Eastern population. Presentation is usually about 6 years of age with recurrent episodes of anterior or posterior blepharitis, sometimes associated with recurrent styes or chlesia. Constant eye rubbing and photophobia may lead to misdiagnosis as allergic eye disease. Conjunctival changes include diffuse hyperemia, bulbar phylactery, and follicular or papillary hyperplasia. Corneal changes include superficial punctate keratopathy, marginal keratitis, peripheral vascularization, and axial subepithelial haze. Treatment is with lid hygiene and topical antibiotic ointment at bedtime. Topical low-dose steroid prednisolone 0.1% or fluoromethanol 0.1% and erythromycin syrup 125 mg daily for 4 to 6 weeks may be also be used. So basically, the BKC is the condition of the childhood, and in which all the things are affected. Blepharitis mean the lids are affected, kerato mean the cornea is affected, and conjunctiva mean the conjunctiva is also affected. So the patient in present with the blepharitis in the blepharokeratoconjunctivitis, and the conjunctivitis signs are the basically the follicular or papillary conjunctivitis, and the corneal changes are the superficial corneal punctate keratopathy, marginal keratitis, and you treat it with the topical antibiotics and the lid hygiene. And it is a condition that is usually in the Asian and the Middle Eastern population. So that's it for the eyelid part 8. See you in the next lecture.